So you can say yours, I'll say some of mine, Cap will say some of hers.
Well, okay, first of all, my biggest advice would be don't stress too much about it. Honestly, it's just a pass grade only. So you either at the end of the day, either pass or fail. So you just got to pass the assignments altogether. So don't stress too much about it, just because there's so much stuff during like med life, like, a lot of work from the course, as well as, daily life, I guess. So if you spend a lot of time on your assignment at the cost of, maybe doing extra or doing work or catching up on lectures, that's not really that recommended. So that's my first and biggest advice. Don't worry too much, don't stress too much, don't try to be too perfectionist. But obviously, if you have a lot of time on your hands and you do want to give it your best try, I'm not quite sure exactly which assignment is due on Monday for you guys, but do you know which one, David, or is it all three?
Yeah, it's in the chat. I'll just copy paste it again.
Sure, okay. Yeah.
What's OCE? Is that like your OSCE?
I guess OCE is OSCE.
You guys
That doesn't make sense.
Interesting.
Yeah, it's your reflection. Oh, that's chill. Okay.
That should be fine. Yeah,
So
so
HLS.
oh, they all due at the same time. Okay. Yeah, well, so for HLSD, personally, what helped me a lot was actually making sure I understand the question. So like the questions, I'm not quite sure exactly how they fixed it this year, but when we did it, it was like our first kind of year doing it on like a person that we never talked to kind of. So it was kind of hard a little bit because like the examples they gave, it didn't really make a lot of sense. The question itself kind of seemed very vague. So it's very important to make sure you understand the question first and think what type of meta language or what type of things can I write that I've learned from the lectures regarding this topic. That's really important because obviously you got to use the words or the things that they've taught you in this assignment. That's how you want to get the marks. And also read if I'm pretty sure they would have given you sample answers or question and answer sessions they had where they asked questions about how do you answer this question, blah, blah, blah. Make sure you read up on all of them because faculty loves to keep changing what they recommend or what they say they will test you on. So make sure you understand exactly what's happening with that. Anything else from you guys regarding to HLSD?
Yeah, so something I found helpful is you'll have a set of frameworks Kat explained last session, like that's including Erickson's and Freud, etc. So what I would recommend, if you haven't started, or even if you have, what I do first is read over your person and have a good understanding of the events of their life, and then read over the theories and apply. When you're reading the theories, for example, you read Erickson's stage and see, can I manipulate something in my person's life to fit this stage? And then use that as a structure. That would be my number one recommendation, is reading through the theories with the person in mind, and then it's easier to implement that way. I also found going chronologically throughout their life was a nice way to structure that if you want something easy. Yeah.
And use as clear examples as you can, like direct examples, if you can't find them regarding to those stages. Anything else, Kenya? Or
yeah, so I was just asking in the chat if you guys had a chance to choose a person. So for us, we could choose like a well-known figure or like someone we know we had to make like a really good case for it. My tip is if you're choosing a well-known figure, make sure it's like really, 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 really well-known, because you're gonna have to dig up stuff like from their childhood. And if they're just like kind of relatively famous, but on Wikipedia you can't find stuff from their early life, I wouldn't do it. Like I had to go through like several guys before I found one that could genuinely, I read like the autobiography on, just like to skim through like all the childhood things and all the developmental things. Okay, so apparently you have a list of 6 well-known people you can pick from. Yeah, have a look on the Wikipedia page and see like what you can come up with. And then secondly is I would just kind of list all the theories we have and then see which one kind of works the best, because for different people you'll have different theories that might work better. So just go with the one you have the more information on, honestly, because it's just show that you can apply the theory. So the more information you have, the better you can apply it. That would kind of be my tips.
Yep. Yeah, so I guess they've decided that having everyone choose a different person was very hard last year, because you could choose, I think you couldn't actually overlap. So they had probably like 340 different people that they had to go through. It's smart of them to just trim that down. Okay, and regarding EPI assignment, this one, I personally found it kind of hard at the start because I was like, I was kind of behind on the lectures as well. And I was like, what the was going on? I found it very useful to actually read the article and the journal like really carefully and watch the lectures again, because I'm not quite sure exactly what lectures you got this year, but if it's very similar to last year, it wasn't that long from memory. And when you watch the lectures, think about the questions that they're asking in that assignment, because it will be in question and answer form from what I remember. Then try to think, okay, exactly what are they asking? And then use that to answer the question. It's really important to, again, understand what the question is asking, but also use the content from the lectures and really understand your article as well. Yeah. Anything else, guys? Or
Was that for EPI or?
yeah, EPI.
EPI. Okay, my biggest recommendation for EPI, and we're doing ethics now, what I'm realizing as well, is that they mark you based on dot points. So when you go through it, dot point 3 points for a 3-mark question. Don't just write, because they hate reading. It's not like school. They don't really care how well you write. Like,
It's not
just
English.
hit the points and get out, sort of thing.
Yeah.
That's a big recommendation. And for all assignments, always start as early as possible, which is easier said than done. I've got a couple of questions here. Do you recommend any resources, useful references for the 3 assignments? So for HLSD, I think the lecture frameworks are pretty good. I searched up a Freud stuff. It wasn't necessary. And otherwise I based it on Wiki. Wiki is really great if they're famous, because it has enough. And they allow you to use, they recommended Wiki for us last year. Okay, quickly, a quick question for the EPI assignment. Can we work on it multiple times, or does the quiz only let us go in once? You can definitely work on it multiple times.
Yeah, I think there's a submit button at the end, which if you press that, I believe that goes through, but it saves otherwise. If you
you can keep opening it from memory.
In terms of resources, you guys have any other ideas?
Resources as in like, where do you get the information from, is it?
Yeah, just any recommended resources for these assignments.
We haven't gone through rule yet. For rule, I found that there was actually an actual like monashhealth.org website, which had the services. I'm not exactly quite sure which scenario you guys got this year, but we had one about kidney dialysis last year from memory. Well, I mean, at least my group did. I actually even called up one of the specialists that work in this rural area, and he told me that there was no kidney dialysis system. So I was like, oh, okay, bet. I'll make sure I write that down. And then in my whole group, because my whole group was carrying me so hard, everyone got full marks except me. And there was that 1 mark. And it was that 1 mark because apparently there's a kidney dialysis system in the place that I got, which was a Warrigal. So just use the site. I trusted the specialists, but apparently they don't. They just use the website. So there's an actual website called monashhealth.org, which I can send you guys a link, but I'm not quite sure exactly if it's the same one for this year. But yeah, definitely using proper resources is recommended, like .org, credible websites.
Yeah, I agree. In EPI in particular, they really don't expect you to do kind of any other resource searching apart from the ones that you do in the lecture.
Well.
Yeah, you shouldn't. So you don't have to reference anything. You can if you want to, and there are a couple of cases where they want you to look at stuff they give you. But other than that, they really don't want you to go into the other webs or other dark trains of EPI and biostatistics. So keep yourself restricted in the lectures. That's plenty of space. For HLSD, just kind of the frameworks they sort of give you, I wouldn't if you haven't done the lectures, I wouldn't necessarily do the lectures. I might just go through the lecture slides and pick out the theories, because HLSD is kind of, they have a bunch of random facts, and then they have the theories kind of in between. So just look for the main theories, Erickson's, Watson's, Freud's, and make sure like you have those down. Otherwise, I wouldn't necessarily be like rewatching all the lectures now. I'm actually looking through my EPI assignments right now, and the places where I lost my marks was on specificity. So places where I was like, oh, they divide into 3 groups, but didn't say like what the 3 groups were. Or somewhere else I'm talking about, oh, it was like more, it wasn't less. I wasn't saying like how much more, how much less.
Yeah. Yes.
So like be super, super specific. And the second place where I lost the most marks in EPI, which is so sad, is that there was a place for us where we had to insert an image. And you're supposed to like draw out a study design, like what study design it was, and like show it on a diagram and insert it into the quiz. My quiz, for some reason, was malfunctioning and it didn't let me insert it. Like it said I inserted it, but it actually didn't insert it. So I lost 5 out of 5 marks that question because it wasn't there. Richard later recounted it, so he gave me half the marks, so 2.5 marks. But just make sure if you're inserting an image, even if it says it's there, like make sure it's there, like click on it to make sure it comes up, or do it multiple times, because don't be like me.
I had the same problem with that. So in our, we had one this year, and I thought I had submitted it. I saw it, and I submitted it, and they said they couldn't see it. So they looked through my last saved ones.
Yeah.
So just be extra careful about that.
Exactly.
Yeah. I just had some questions about the rural assignment just then. So one person asked me, is in rural health, do you get separate marks, even though it's a group assignment? No, you don't get separate marks, but normally it will depend on how your groups work, but normally you divide. There's going to be like different sections that have different amount of marks, and you divide them fairly among your groups, so you have equal amounts of things to do, except you don't need to do the whole assignment, right? So I had my section, and in my section, I clearly saw 1 mark loss, and I was the only one who contributed to it. So that's how I knew that I was the wrong one at fault. But you still get the same amount of marks. So if you got 90 out of 100, then the whole group gets 90 out of 100, even if one person got 10 marks wrong. Okay, so it's a group assignment. And also one other question was, did you mention Warrigal had the dialysis center? Now, I actually did not read into the actual website. From memory, the comment was that my mind map had identified a dialysis center is present. And then in this written assignment section, I said there wasn't. So they said that was this mismatch, and they did tell me that if you go onto that website, it will tell you that they did have a dialysis center there. So I believe there is one, but don't mark my word. But if they did say just refer to that, but I was like kind of pissed. I was like, stop it. 1 mark off, that'll be fine. So yeah.
We've spent quite a bit of time on this, so I'll just quickly say my question, and then we'll quickly do rural health and then move on. So someone asked me, so is it totally fine to answer in the dot point form? We won't lose structure marks or anything. So I'm not going to lie to you. I asked this question today to someone. I don't know. It depends on the lecturer. When you ask them, some of them will say it's fine to dot point. Sometimes they won't, and it does depend on the assignments. I was just referring to when you plan it to dot point it. So when you write it, you have 3 points. You can write the 3 points and get out of it. I know for ethics, dot pointing is fine because his answers are in dot points. I wouldn't for EPI. I don't think I would. I'd just make sure you have the short answers, 3 points, get out of there.
Yeah, main point is being concise, I think. As David mentioned, is like if you plan it in dot point form, you want to write it in much concise and direct to the point that they want you to get to, instead of bubbling on about like different things.
Yeah. Someone asked if there are 5 marks per question for EPI. Does that mean we need 5 points in our answer? Not necessarily. No. Just be comprehensive and answer the question, but do it to the point. Don't waffle. They hate it. They hate it more than anything because they have better things to do.
I also know that they said to use the reference of the text box as your thing. If you have a big monitor like I do, be careful, because I realized that it becomes much bigger. So I end up writing over like 2,000 words at the first draft. So make sure you don't just use that. Like make sure you understand there is technically some word limits for some questions on some assignments, not always, but there's definitely a whole, like the whole thing will have a certain word amount. So I would recommend always making sure you check on your Word document to see if the amount of words you have is definitely within the range they want you to have. If not, you might just completely go over or under.
Yeah, I completely agree. I'll just add my 2 cents for the rural assignment. The way we had it, it was in 2 parts. The first was like a mind map of like the rural kind of location, like the services available. And the second one was like the written assignment. For the mind map, I'd recommend get a platform that everyone can like contribute on. Like you can share the mind map and people can like add to it. Because we did it first on a platform where like only one person could edit it at a time. And that was just way too complicated. It's better like when everyone can change it. For the written assignment, the biggest thing I'd recommend is add subtitles. Like the essay is really long. I think ours was, I want to say 3,000, David, not quite sure. There's like multiple thousands. And titles really helped identify the structure a lot more clearly, because without it, it was just like this huge chunk of text. It was like, you get lost in it. So I would just say, make sure you have subtitles addressing like each of the criteria that really helped our group.
Some advice from that from me is I recommend with your groups as frequently as possible, because you are marked for the coherence of it, and there's frequently misunderstandings between groups. So in our group, we met at the end and we realized we were all way over the word limit, because everyone just thought we'd slightly go over the word limit, and everyone did that. So then we all had to cut down together, and then we had to read through it together, and it was just a lengthier process. Rather have regular meetings, discuss what you've done, even if it's not a lot, it's fine, just so everyone's on the same page. And you actually, because some people are too afraid to ask, and then you've got someone doing something completely wrong, it's completely different. So just check up all the time. Also encourages you to do it.
Yeah, I found definitely having more meetings the better. I had like one every week, every day, just because I actually got into a lot of group that also had a lot of people that were very enthusiastic about it. This is med, so don't be afraid. Don't think you're trying too hard. Don't obviously go like, let's have a meeting every day, but like, don't be afraid to ask if people are willing to have a meeting. Plus it's Corona and lockdown. I'm pretty sure they have really nothing better to do. And they'll politely reject you if they don't want to do it. So don't be too scared to ask people about it. I think that's it, right?
Yeah, so I think we'll start moving on now. We have only a little more than 2 weeks for our rural health. Yeah, plenty. 2 weeks is enough. You could, I think that's more than enough time.
We did ours in 4 days. Don't recommend it, but it's easy
you
to
could do it in a night, frankly. Most people aren't as on top of it as Peter's group was. So don't get worried. But so I think we'll move on. Kat, do you have slides for this one?
Sure.
Okay, so we'll start with Katja, and then we'll decide whether we do farm or lower limb. I'm going to have a look through the lower limb to see how much there is.
All right, I'll just get it up, sorry. All right, apologies if I kind of look towards the right. That's just because all the slides are kind of on the monitor up here. So first I thought I'd go through kind of the pop health and the EPI exam questions you'd face, because I remember that's something I was wondering when I was going through this in year 1. I wasn't quite sure what exactly is examined and what's not, because you might find in like other subjects, like, I don't know, like biochemistry, like quite a bit isn't examinable and like only certain things are. So that first kind of paragraph with those 6-7 dot points is what was like directly tested on our exams, and like is quite regularly tested every year. The kind of bottom 3 is what has come up from time to time. It doesn't necessarily come up all the time. So the first one there is the study design questions. So last week we went through the study designs, like the cohort study, case control, that kind of stuff. The way they test you in an exam is they give you like a paragraph explaining kind of a study, and then it's usually an extended multi-choice question. So you have like A to I of like all the study designs, and you have to say like which one matches where. And they usually have like 3 or 4 of these paragraphs. You have to choose which one matches. The second thing they quite regularly test is sensitivity, specificity, positive predictive value, negative predictive value. You'll hopefully do this in a couple of weeks. It's just like you have to find stuff from a table pretty much and see like how well a test is and like how likely like false positives are or false negatives. It's quite straightforward once like you do learn it, just thought I'd flag that. The third thing that's quite regularly tested is calculating relative risk and odds ratio. The fourth thing is disease history. And this is one that I distinctly remember last year in the exam because I got it wrong. As always, you remember the questions that you should know and you just don't remember how to get right. So this one is like the stages like of a disease. So there's like the latency period, the infectious period, and the incubation period. Just make sure you kind of know the definitions of each of these. It's very straightforward, and especially with COVID. Like I'm sure you guys all know it, and we'll go through that in next week's class anyway. Bias, so lead time bias and length time bias. That was like a question on what type of bias is it, or what does a bias mean? And then the last thing that was like always regularly tested is the level of prevention. So there's like different ways of like prevention and treatment. So there's like primordial, which is like about structures, primary, secondary, and then tertiary prevention. Once again, we'll go through like all this. I just thought it would be a good overview of what generally is tested quite regularly every year. The stuff that like maybe is tested and comes up like maybe like one question on the exam, other 3 dot points down there. So calculating attributable risk or population risk, it definitely does come up, just not as much as like relative risk or odds ratio. Confounding variables, like the definition of it. And then as you'll see next week, there are a bunch of like kind of random tests that they do with like quantitative data, and or categorical data as well. And there's like chi-squared, 2 sample t-test, linear regressions, 1 sample t-test, ANOVA. You really don't have to know these like at all. Like they only come up like maybe like 1 or 2 questions on an exam. It's a bit random. We'll go through it. But I wouldn't spend my time necessarily learning all of those tests. I would focus more on like on the stuff in the first paragraph. So anyway, that was a very long prelude, but since we're talking about assessments, I thought I would bring it up. Let's go into sampling. So this is just a quick overview of the document I had up last week, just so I'd have it here going through each of the case study designs based on the experiment in green. Just so you guys want to have a look at that again. So here are kind of all the main calculations you might have, and the way you usually have to do these is they give you like a table, and it's like smoking, non-smoking, rate of lung cancer development. And using the data in the table, you have to calculate these things. So I'll just go through the definitions of each of them. First is relative risk. So it's the risk in the exposed, like exposed to like asbestos, for instance, divided by the risk in the unexposed. And the risk is usually referring to like developing disease. So the risk of developing lung cancer, given that you're exposed to asbestos versus not exposed. Attributable risk is just a simple subtraction equation. So it's the risk in exposed minus the risk in the unexposed. Attributable fraction is the attributable risk, so that risk in exposed minus risk in unexposed over risk in exposed times 100 to get a percentage if you need one. And the way that you'll see this is that they'll ask you like to calculate the attributable fraction, but then they'll also have what I have in brackets as well. So they'll tell you that the attributable fraction is the percentage of cases that can be attributed to the exposure. So you don't have to know the definition, like what these mean. They'll give you the definition there. You just have to know how to calculate it, the formula behind it. Population attributable risk is asking about like the whole population, how much can a certain disease be attributed to a particular exposure. So for instance, my population is like, I don't know, 20-year-olds, and then how much of liver cirrhosis can be attributed to alcoholism. Like if I took that away, how much wouldn't get liver cirrhosis anymore? And then the population attributable risk percentage, similar to the attributable fraction. So yeah, these are just 5 kind of formulas that you do need to know. And I just had a question come through asking, is risk a number of people or a percentage? Okay, so risk is usually expressed as a percentage or like a 1 point something, like a 0 point something, specifically relative risk. For everything else though, it's usually per an incidence rate. So it's like population attributable risk might be 12 cases per 10,000 people. So it's usually per like a certain number of people, however they're calculating it. The exception, yeah, David?
I was just going to say, yeah, so I think the confusion with that is just why that subtraction is there in terms of the percentage. But it's like what Kat said, it's in like 10,000 people. So you're subtracting the 12 minus the 6 in 10,000 people.
In 10,000 people, yeah. No, thank you. This David mentioned last time, and it was going through relative risk. So relative risk, the formula's up there, the risk of the exposed over the unexposed. That's usually expressed like as a 1 point something, like a 0 point something. So if the relative risk is 1, it means that the chances of getting the disease if you're exposed to something versus not exposed is the same. So for instance, here maybe let's say the exposure is something like grass, and the disease is lung cancer. So the risk of being exposed to grass, so the risk of lung cancer, whether or not you're exposed to grass, is the same. So the relative risk is 1 because whether or not you're exposed to grass has no impact on the lung cancer. If it's greater than 1, it means that whatever you're exposed to makes it gives you a higher chance of like being caught with that disease. So something like smoking has a relative risk greater than 1. So if you're exposed to smoking or cigarettes or tobacco, you're more likely to develop lung cancer. And anything that's less than 1 means it's a lower risk, so like exercise. So if you're exposed to exercise, that means you're less likely to develop lung cancer than people who aren't exposed to exercise. And that becomes a preventative factor or a protective factor. Someone else has just asked me, how do we know how many people it's out of? They'll definitely tell you. It'll be like 12 per 1,000, 12 per 10,000, 12 per 100,000, 12 per million. It'll definitely be up there. This is a very, 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 very simplistic worked example. And the reason it's very simplistic is usually for relative risk, you have to do a few more calculations. So that's why here you can see the answer is not in like it's usually like a 1 point something, like a 0 point something. But like the principle behind it is the same. That's why I thought I'd have it up. So on the right there, we have a table of non-smoker, smoker, and then the incidence rate of lung cancer. So in a let's say that's per 1,000 people. So for a non-smoker, the chances of them getting lung cancer, like throughout their lifetime, is 10 per 1,000 people. So 10 out of 1,000 will get lung cancer. For a smoker, it's 120 per 1,000 people. And total here is like the general population. Like the general population of Australia, regardless of their smoker or non-smoker, how likely are they to get lung cancer? Well, it's 30 per 1,000 people. So the relative risk is the unexposed over the unexposed. So here the exposed is your smoker, so 120, and unexposed is your non-smoker, so 10. 120 divided by 10 is 12. So usually here, the risk you'd calculate like in the previous question, and your answer would be like 0.9 divided by like 0.7 or something. So usually you get like a decimal, like a 1 point something or 2 point something or 0 point something answer. Here it's 12. So just keep that in mind. It's not going to be like that all the time. So 12 per 1,000 people. Attributable risk is just the risk difference. So your risk in exposed to smoke is 120 per 1,000 minus 10 per 1,000, so 110 per 1,000. That's the difference in risk between people who smoke and people who don't smoke. The fraction is your answer to the attributable risk, so 110 divided by risk in exposed, so divided by 120, because that's your smoker, and that's 92%. So that means, what that means is that 92% of cases of lung cancer can be attributed to or like explained by smoking. So 92% of all cases of lung cancer is caused by smoking. Population attributable risk is talking about the wider population, so like general Australia. So the total population risk, we have 30 cases per 1,000 people of lung cancer, minus the risk in unexposed, so that's 10, so 20. So as a population, like overall, 20 cases per 1,000 people can be explained by smoking. It's like as a population. And then the same with the percentage, so that's 20 divided by the total risk, 30, so that's 67%. So as like a population overall, 67% of our lung cancers come from smoking, like rather than an individual. So that's just an example. All right, the second part is types of sampling. This is like very rarely tested. I don't think I've seen a question on this. David, Peter, feel free to correct me if you have. I feel like it's never come up. Maybe convenience sampling. That's kind of it. So yeah, sorry, David, do you want to say something?
I was going to agree with you.
Yeah. So simple random sampling is just, I pick names out of a hat. So every person has an equal chance of being in my group that I'm going to experiment on. Oh, so just to clarify, population is like the group you're studying overall, and sample is like the specific people you did the experiment on. So my population might be like med students, my sample is you guys. Convenient sampling is when I choose my sample because it's easy to find and it's convenient for me. So for instance, med students, and I choose you guys because it's convenient. I'm not going to like make a random hat allocation for everyone. That's just too much effort. Voluntary sampling, when you just sign up to participate. So like you send out a Google form, people sign up. Systematic sampling is you randomly choose one person and then take the next person with a constant gap of people in between. So like, for instance, I were to rank you guys all academically, and I take like every third person. So take rank 1, rank 4, rank 7, rank 10, which is actually what they do for your placements in year 3. That's how they decide who goes where. They just split everyone up. So technically each cohort is like equally smart in like each location. Cluster sampling, where I just divide you into like groups, and then I just randomly choose a group. And stratified sampling, which is the same thing, except the groups I divide you up into, I like choose the group. So for instance, I'm like, okay, this is a group of like all the girls, this is a group of all the boys, this is a group of like all the swimmers, this is a group of like all the runners, I don't know, whatever's relevant to my experiment. And then like I take one person from each group to make sure it's like a fair experiment. So that's sampling. Types of data, this is kind of only relevant in relation to the tests. So we'll do the tests next week, like the t-squared 2 sample tests. But there are 2 types of data, categorical and numerical. 2 types of quantitative data, I should say. Wait, no, because categorical isn't quantitative. Never mind, ignore me. Numerical is quantitative. Categorical is like more qualitative. So categorical, you have like nominal and ordinal. Nominal, think like N for like no order. So it's stuff like blood type or stuff like gender, stuff like postcodes. There's like not an order to them necessarily. Ordinal is when you have an order. So like if I was to ask, rate how you're feeling 1 to 5, there's an order to that. Or like BMI, like weight, there's an order. But like my categories, so like healthy, overweight, obese. Numerical is like when I have actual numbers. So continuous is like more like a measurement. So it's stuff that I can't drill down into like one number. So like height, for instance, could be like 173.1905432. Like it keeps on going. Like it's kind of no endpoint. You can say let's round it to the first point, but there's actually no genuine endpoint. And discrete is just like numbers that have an endpoint. So like number of pets. Like you don't have 2.5 lizards, you have 2 lizards or 3 lizards, because if you have half a lizard, that's slightly concerning. Types of error, we have 3. We have random error, which is just error that happens by chance and inexplicably almost. Biological variation, it's like the whole mutation stuff. People are naturally slightly different. I could take a group of like German swimmers and then do an experiment on them, but the results still might be different from person to person because they're different people, even though they're the same kind of group of people. And systematic error, which is kind of the only one they usually test you on, is stuff like measurement bias. So like your instruments aren't calibrated properly, or selection bias or recall bias. The idea with systematic error is that it's supposed to affect each data point the same. So if I was to measure like all of your heights and my ruler was 2 centimeters off, it means that every height is adjusted by 2 centimeters. So like it's like all gone up or all gone down. That's the idea with systematic error. That's supposed to be like all the same difference. Sample size, if you have a too small sample size, you can't generalize. And then confounding. The most common type of confounding they'll ask you about is like the third variable. So it's the idea that you can have a relationship with something, but that doesn't mean that they're actually connected. So stuff like, you maybe heard like if you graph the number of ice creams people eat and shark attacks, you'll see like they kind of follow like a linear line. And that doesn't mean that eating ice cream will cause a shark to like jump out of the water and eat you, right? The thing that's connecting that is water. So like people go to the ocean when it's hot, and when it's hot, they also eat ice cream. So they're more likely to eat ice cream, and they're more likely to go swimming and get eaten by a shark. So that's the idea with confounding. There's like another variable in play. And that's something that's actually really hard to detect. And that's why they do systematic, not systematic, like meta-analysis and systematic reviews to make sure that there's not like a third variable going on. So to control for confounding, we can have control at the design stage. So like the more random sampling you have, the better, because everyone has an equal chance. Or at an analysis stage, so making sure you're analyzing things properly, making sure you're seeing if there's any other experiments that have like the same kind of variables. So just doing some analysis. All right, I think this is like the second last slide or the last slide. Validity and reliability. Validity is pretty much how well does the experiment measure what it's supposed to measure. And reliability is more like how consistent or reproducible is it. So validity is like, at the end of the day, did my experiment actually give you the answer you're looking for? So there's internal validity, like is it valid among the group being studied? Like if I'm doing, I don't know, an experiment on you guys about like how much you study, like is my answer that you study 2 hours a week, is that like a valid answer? Is that like true? And then the external validity is like how generalizable is it? Well, if that's true for you, is that true for like all med students at Monash? If that's my population. Reliability is about like consistency. So if I was to measure how much you guys study and there's like 2, that's very consistent. And reproducible, if David did this experiment, would he find the same results, or would you guys tell David you study more than you tell me? Like, is something going on there? All right, last one. This is sort of linking into what we'll do next week, diagnostic and screening. So this is related to the length time and lead time bias stuff, as well as the PPV and NPV, which we'll do later on. Diagnostic is pretty much when you're investigating symptoms. So a patient comes in, they tell you they're tired, and you use tests like a blood test, try to check their iron levels, try to see what's going on. Screening tests is when they have no symptoms. So they come in and you're like, let's check your iron levels. So it's performed on an apparently healthy population, and it's stuff like your parents might get like a letter asking them to like check their like bowels, and they have to like submit like a bowel and like send it off for like blood. That's like a screening test, just checking the wide population to see what's going on. And yeah, that is it for pop health.
Thanks so much. That was really, really good, as always. I'm going to share mine now. I had a look at the, one second. I had a look at the lower limb, and it's essentially just notes. So we might go through that at the end if you have time. Why is this not showing me other things? Okay, I'm just going to go share screen. Excuse the thousands of tabs. Okay. So this is a substantial farm week, and we're essentially talking about drugs that prevent pain or inflammation or other sorts of damages. So to begin with, we're going to talk about anti-inflammatory drugs with a particular focus on simple analgesics, which are drugs such as paracetamol, and NSAIDs, which are drugs such as ibuprofen. So to begin with discussing how do drugs affect inflammation or inhibit inflammation, we first need to understand what inflammation really is. So inflammation is classically divided in these 5 pillars, the Latin 5 names, which you don't, pallor, etc. So you need to know heat, redness, swelling, pain, and loss of function. Hopefully you remember it from first semester. And these often inflammatory results are as a result of inflammatory mediators. Some of these inflammatory mediators are autocoids, so they're released from the site of damage, and these include histamine and bradykinin, and they're released in inflammation. There's also soluble proteins such as cytokines that are involved in the inflammatory process. And you remember some interleukins are involved in that, like damage in that inflammasome, in that damage response. So many of these inflammatory responses induce pain, and often the pain is really uncomfortable and to an extent pathological. And in that sense, we want to inhibit that pain. And a type of drug that works by inhibiting inflammation is NSAIDs. Now, an important thing to remember is NSAIDs prevent against all of these functions. They don't really prevent against loss of function. Steroids are more effective at preventing loss of function, which we'll discuss later. So NSAIDs are non-steroidal anti-inflammatory drugs. They block prostaglandins, which underpin the inflammatory response. We've discussed, as you would have remembered from last sem, how inflammation is really underpins leukocyte division and the leukocyte response, and really the deposition of fibroblasts and the healing process. But there's also situations in which inflammation can be dangerous, such as when it's life-threatening and anaphylaxis, which is a release of mast cells. When you have damage to your own cells and tissues with a loss of function, for example, in rheumatoid arthritis, which is an inflammatory arthritis, when pain is debilitating and has an effective and substantial consequence on quality of life. These are especially apparent in chronic pains. And the inflammatory response also underpins autoimmune diseases where an immunopathology is evident, and you want to inhibit that through the use of NSAIDs to affect that inflammatory response. This is an overview of the pathway that produces prostaglandins that lead to that inflammatory response. So you're going to have a phospholipid that's cleaved off by phospholipase A2, and that's going to produce arachidonic acid. And if you can remember from last sem when we discussed omega-3 and omega-6, arachidonic acid is a derivative of these. So they do lead to eicosanoids, which are omega-6 and omega-3 derivatives and have a variety of functions. From the arachidonic acid, you're going to further be broken down by this enzyme called cyclooxygenase. And this enzyme, cyclooxygenase, is what NSAIDs will act on. They inhibit this to inhibit the inflammatory process and to inhibit the production of prostaglandins, which are all of these PGE2, PGD2, PGE2, PGF2, etc. So all of these PGs. As a point of interest, there's a substance called thromboxane A2. This is a vasoconstrictor and platelet aggregator, and it is often targeted by aspirin to limit the clotting effect and enhance bleeding. Another reason why it's important is it has these remnants called TXP2, and TXP2 can be measured to see the amount of kind of the system going through, this inflammatory system. So in order for that to make more sense, remember thromboxane A2 is opposed by this prostacyclin metabolite. These two have opposing actions in the body, and in order to measure that homeostasis, you can measure these little derivatives in the blood to see if the balance is okay. The most important things for you to remember, and I'd say only things for you to remember, phospholipase A2 is inhibited by steroids, cyclooxygenase is inhibited by NSAIDs, and the function of simple analgesics is not presented in this image. Again, just to go over eicosanoids, arachidonic acid is a precursor to them. They often act as paracrine hormones that act on targets nearby the point of synthesis. They're essential in blood inflammation and clot formation, which we've seen. This vasoconstriction and platelet aggregation is important for that clot formation. They're involved in cell-to-cell communication, which is part of the inflammatory response, and smooth muscle relaxation and contraction, which is a little different. That's referring to uterine contractions, I believe. So these are slides from last sem. These are some derivatives, eicosanoids. They synthesize prostaglandins, which are important in inflammatory response and in pain, elevate body temperature, which can cause fevers. You have leukocytrines, which are potent chemical messengers. And one of the reasons that NSAIDs can sometimes be contraindicated in asthmatics or can be a little dangerous in asthmatics is leukotrienes can cause, in overproduction, they cause an asthma attack. And if you see this image over here, if you're blocking the cyclooxygenase pathways, this leukotriene, there's going to be a forward reaction favoring leukotriene production. So just keep that in mind. It can also induce airway contraction, and a thromboxane A2 is involved in blood clotting and is targeted by aspirin. Is there a question in the chat? Leukotrienes in all people or just affect asthmatics? So if we go back to that slide. Leukotrienes are potent chemical messengers. They have a role in all people, but they're particularly potent in asthma attacks because those people are particularly susceptible and have particularly adverse effects. And you'd imagine it has some sort of interaction with the histamine release and the contraction of the airways. So it is involved in potent chemical messaging, which is involved in the immune response, but really you just need to recognize it in terms of asthmatics. Here is the action of prostaglandins. Does that make sense? Hopefully it does. This is the action of prostaglandins. You can see it's involved in pain through sensitizing afferent C fibers. Now this confused me a bit at the start. To sensitize a fiber means to make it more sensitive to pain. I used to think to sensitize a fiber means that it's like less, it makes, don't worry. I used to think of the opposite, but don't think that. It sensitizes it to pain. It lowers the threshold at which it experiences pain. Prostaglandins such as PGI2 are involved in vasodilation, and that can lead to heat. Remember, blood is warm, and if you have vasodilation, you have more blood going through and your skin's going to warm up. Can lead to fever during CNS actions, which I don't understand, and lead to swelling due to increased capillary permeability, which leads to potential edema. An important relationship to understand is the relationship between prostaglandins and histamine and bradykinines, which are these autoquote inflammatory mediators. So histamine and bradykinin are sensitizing C fibers. Do you know what C fibers are? They just transmit pain, generally more long-standing pain. So histamine and bradykinin will trigger these C fibers with histamine and bradykinin, but the prostaglandins will lower the threshold. So you'll have an even more substantial pain response. Does that mean we can still prescribe topical NSAIDs for asthmatics? Yeah, you probably can. It's not a huge, it's not actually very examinable, and it's not a huge factor. But yes, I would imagine you can prescribe topical, especially we'll talk about in a second. Topical doesn't have huge systemic effects. But again, I'm not 100% sure. I imagine you can. I mean, I have friends with asthma who take NSAIDs, so I do imagine you can. Interaction, I think it's more of a precaution. Just beware that they're more susceptible to this situation and to look out for it if they do. This is just to show what I've just said before, the interaction between these pain-enhancing signals and the pain-producing signals. So your bradykinin and histamine are going to produce pain and simulate your C and alpha fibers, whereas your phospholipids and eventually your prostacyclins are going to sensitize them, so less trigger is required to cause pain. I do have a slide on C and delta in the anesthetic section. Okay, this is just a pyramid to show you like the intensity. So usually you're just going to start with a simple analgesic. Simple analgesics don't affect the inflammatory pathways we discussed before. They don't have very severe adverse effects and are effective in small to mild pain processing. NSAIDs are a little bit stronger. They are going to lead to some adverse effects in this diagram I've shown you over here. Now, there's something called COX-1. We'll get to in a minute, but some of these prostaglandins are really important for the functions of the body. For example, they lead to production of acid in your stomach, which means like kind of makes you less susceptible to peptic ulcers. They're important for kidney function. So these do have important functions that when you inhibit them, they're responsible for your adverse effects. I put steroids here. They're next in line. They act upstream to all of this, so they'll have more significant pain inhibition, but also more effective adverse effects. Opioids affect on neuroreceptors and nerve signaling, we'll come to later, and then local anesthetics such to really block out pain. Simple analgesics, example you need is paracetamol. Sorry about my Facebook buzzing, but paracetamol is a simple analgesic. Its mechanism of action isn't completely understood. that's really all you need to know about it. It has antipyretic effects and is involved. Antipyretic means it reduces fevers, and it's involved in mild to moderate pain. So some examples they gave, the only one I could remember is period cramp, because I feel like that'd be pretty controversial, but that's the example they gave. Then you have NSAIDs, which are non-steroidal anti-inflammatory drugs. They're pain relievers, they reduce fevers, they're antipyretics, they're indicated in mild to moderate pain as well. They affect platelet aggregation. They can be indicated in migraine, arthritis, and for antipyretic effect, along with many others, so I'm sure you've all had experience with. They do have a role in inflammation. These include, so sorry about that, I meant to put that in. I initially had this all come together and then I separated it into two categories. That's why that's in. So some examples of NSAID are aspirin, ibuprofen, and diclofenac, which is also known as Voltaren. These are a little bit different. Just these in diclofenac is a core drug. It's more musculoskeletal effects, whereas the others are more systemic. Aspirin is good at platelet aggregation. Ibuprofen is weak. Paracetamol has no effect. Most NSAIDs are taken orally. They're highly metabolized by cytochrome P450 enzymes in the liver. That means they'll have a few interactions with things that use these enzymes. And most have protein binding. So if you bind it to a protein, the drug is effectively neutralized until it's ready to be released in the systemic circulation and undergoes first pass metabolism. Another important factor is if you have a lot of the drug, you can saturate these protein bindings and you're going to have a lot of the drug in your system. Adverse effects, you're going to have increased bleeding time due to that antiplatelet function. Peptic ulcers, because prostaglandins maintain gastric acid secretion and mucus, particularly PGI2, and exacerbation of asthma, sometimes synthesized with leukotriene. This is the extent that this is mentioned in the notes, so I'm not exactly sure how effective it is, but leukotrienes definitely have a role in asthma. They have a minor role. There's other more significant factors that have a role, such as histamine. You'll get a lecture on this next year, but they do have a minor role in it. And NSAIDs block the cyclooxygenase. Is there a question? Yeah, so paracetamol is a simple analgesic. There's two types of I pronounce every word wrong. It's remarkable. There's two types of cyclooxygenases, COX-1 and COX-2. COX-1 is expressed in most cells, and they essentially have a housekeeping job. So they keep you healthy, essentially, think of it. So they're involved in platelet aggregation, good vascular flow to the kidneys, mucus secretion in the stomach. COX-2 is induced in active inflammatory cells. So as a memory tool, you would be forgiven for thinking COX-1 are the good guys and COX-2 are the bad guys, to simplify it very substantially. So then you might ask, why don't they just make drugs that purely target COX-2 and leave COX-1 alone? And they tried that, and we'll establish that in a second. But essentially, most NSAIDs target both. And your therapeutic effect is mediated by their COX-2 inhibition, which is involved in the inflammatory response. And their adverse effect is it's generally involved in the COX-1 inhibition. Aspirin is a drug that's a bit of an exception to that. In high dose, it's non-selective. In lower dose, it's more COX-1 selective, which is why it's quite prominent in platelet aggregation treatment. Why have they not made selective COX-2 inhibitors? They have, and they were essentially found to have a substantial increase in cardiovascular risk, and their damage outweighed their benefit. As a result, many were discontinued. And these sometimes appear in exams. Usually they're not the answer to the question, but usually they can be in the multiple choice section. And just remember the suffix "xib" and you'll be all right. Aspirin overdose. Aspirin is converted to salicylic acid. 30% of aspirin is lost in that first pass effect, where it's metabolized in the liver and broken down by the CYP450 enzyme. And there is a substantial medical emergency involved with salicylic acid poisoning, which can lead to an overdose. And the only question I remember in relation to this is that charcoal is sometimes given to prevent the absorption and treatment of it. I don't know if Kat or Pete remember any questions about this. No, I don't imagine. The thing people get confused is aspirin overdose with salicylic acid and paracetamol and its overdose. So paracetamol has no anti-inflammatory effects. It's a simple analgesic drug, and as a result, it has none of the COX-1 inhibitor-mediated adverse effects. An overdose leads to severe liver damage, really severe. And that's because an excess drug is oxidized to toxic metabolites. So usually it's conjugated with glutathione to limit the toxic effects. If it's oversaturated, there's an overdose. It is not conjugated and there is an excess toxic metabolite. The antidote is N-acetylcytosine. Probably the hardest thing to remember is paracetamol, N-acetylcytosine, glutathione, but it's easier to remember in aspirin, salicylic acid, charcoal. So if it's not that, then it's the paracetamol stuff. This is a summary and the conclusion of our NSAID lecture. This is a summary of the pathway of COX-1 with its physiological stimulus and its variety of physiological effects, whereas COX-2 involved in these inflammatory stimuli. This is just showing you pro-inflammatory refers to redness, heat, swelling, and pain. Remember, it doesn't have much effect on loss of function. It maintains blood flow. Prostaglandins affect blood flow, which is why you can imagine in an inflammatory response, you get vasodilation to have a leakiness of your blood vessels to recruit leukocytes. So they're also going to vasodilate and maintain renal blood flow, and inhibition will affect that, particularly here. And these are some consequences, some of the adverse effects. So while you get reduced inflammation, fever, and pain, you also have reduced renal function, increased sodium retention, ulcers, and bleeding as a potential. Now we're going to talk about steroids. Remarkably similar. You have two types, mineralocorticoids and glucocorticoids. Don't worry about aldosterone much. We talk about it next year, and that's why they put it in. We do talk about glucocorticoids in this semester. These affect metabolism as your stress response. You remember glucagon and cortisol have similar roles in regards to the treatment of glucose. And you have hydrocortisone or cortisol, which is the main endogenous steroid and has anti-inflammatory activity. These are some indications of steroids. Inflammation of the eye, you'll have dexamethasone. Rheumatoid arthritis, give dexamethasone. And now you know you should probably remember dexamethasone because it's mentioned twice. In rheumatoid arthritis, as an exception to the NSAID, not only does it relieve symptoms, but it also prevents loss of function and is often combined with DMARDs, which we'll discuss next week. In allergy, sometimes steroids are given in hay fever, in asthma, and inflammatory skin conditions in a topical area. They have a variety of different routes of administrations, and they reverse the inflammatory reaction regardless of the trigger as well, which is important. So any sort of inflammatory response, whether it's immunopathology, pathogen, anything, you give steroids, which is why there's a joke there's a book called House of God. I don't know if any of you have read. It's about a medical thing, and they essentially say just give steroids to everything, because it just deals with so many causes, and it's very helpful. You have topical treatments and systemic routes. Mechanism of action is over here, where it inhibits phospholipase A2 upstream to our COX inhibition, and it's also going to inhibit your leukotrienes as a result, which is why it's probably effective in asthma. The inhibition is the first step, and it liberates the membrane arachidonic parent fatty acid from the membrane phospholipid. To continue steroids, how is their mechanism of action? So they work by inhibiting phospholipase A2. This is actually quite complicated. I didn't put in the really complicated picture because I feel like it's not worth it. Essentially, the way that steroids work is they act and bind via a nuclear receptor, which is quite interesting. So they translocate all the way into the nucleus. They lead to gene transcription, which leads to protein synthesis and has cellular effects. Can you imagine what the consequences of this would be compared to like an inotropic receptor? Any ideas in regards to onset? Slow, brilliant. That was really quick. Great job. So in this image, essentially it's slowing down as you go from left to right. Steroids take quite a long time to transcript. They also have a pronounced anti-inflammatory effect by inhibiting the transcription of inflammatory genes. It's not very high yield. I just remember the phospholipase A2, but do remember it has quite a long onset because it translocates to the nucleus. You can have steroids endogenously or synthetically. Can anyone think of a possible, this is tough, of a possible consequence? Imagine you've given someone significant amounts of synthetic steroids. What's going to happen to their body? What's their body going to do in regards to the endogenous steroids? stop producing. Wow, so good. So smart. Yes, so it's going to stop producing its production. There's a negative feedback loop. And essentially, that means you've got to be a bit careful when you stop giving the synthetic steroids, because the patient's body is going to produce a lot less of endogenous steroids. Some inflex include, as we've discussed, decreased inflammatory response, decreased leukocyte activity, decreased fibroblast function. Adverse effects, susceptibility to hypoglycemia. As you can remember, insulin takes glucose into the cell. Glucagon and cortisol take kind of deglycosylate. They take the glucose back into the bloodstream. There's growth suppression in children and muscle wasting associated with steroids, osteoporosis due to bone weakening and calcium interference, and hypertension due to aldosterone, which you don't really need to know. Cushing's syndrome is a consequence of excess glucocorticoid production. This is a buzzword. They'll have that reference to someone with a hump, with the redistribution of fat from the extremities to centrally. They'll have stretch marks and striae, cataracts often, buffalo humps is a keyword, and they will bruise easily. That's likely to be on your exam. We've talked about the cortege, which is really good. You got that yourselves. Now, final lecture I'm going to give in pharmacology is about anesthetics. And I mentioned afferent nociceptive fibers when we were discussing bradykinin and histamine. And this is what I was meant by that. You have a whole lecture on pain, which is the most low yield lecture that I've ever experienced. Not a question was asked from it, but it does describe these fibers. You can see how A delta is like the immediate first pain, and then C fibers are a more sustaining pain fiber. These are stimulated up to the higher centers. Yeah, A beta is non-noxious, more of mechanical stimulus, whereas noxious is, this is A delta is also noxious, more prominent. So what are local anesthetics, and why did I just tell you about pain? Local anesthetics work by blocking the pain response. How do they do that? They do that by blocking the conduction of the nerve terminal of the nerves or the neurons. And they do this through a way that's a bit counterintuitive. They bind directly to the intracellular part of voltage-dependent sodium channels. So you're going to give somebody an anesthetic. The anesthetic is going to then diffuse across the plasma membrane and then block it intracellularly. That's going to prevent the influx of sodium, which is going to prevent downstream conduction and impulses. There's a chemical structure associated. There's 3 parts of the structure. You have a lipophilic group, which is an unsaturated benzene that allows it to enter the cell. You have an intermediate bond. This is the most important type because local anesthetics are divided into an ester group and an amide group. And you have a hydrophilic group, which is less important, but this is quite important. And on the next slide, I've showed you a comparison of it. Richard said the way to remember that is amides have an I in it, and all these drugs have an I in it. So that's how you remember if they're amides. Lignocaine is in an Adam Sandler movie, which is how I remember it. And yeah, essentially they're different in regards to amide metabolism is via the liver, and the metabolites are water soluble, where it's excreted by the renal, whereas these are broken down in the tissue esterases. Is there a question? Wait, can you say how we remember it again? That's funny. When I first learned this, I also didn't remember what he said, how to remember it. So the way to remember it is amide has the letter I in it, and these drugs have the letter I in them. I kid you not. That's what it is. So like prilocaine has the I, lignocaine has the I, bupivacaine has the I. And these also, why I was confused, these have I's too, but these I's are at the end. These I's are more prominent at the start. Whatever works for you. So what makes an anesthetic potent? The more lipophilic agents are more potent as anesthetics because they're more able to diffuse across the cell membrane. Furthermore, more potent anesthetics are weak bases because as a weak base at physiological pH, they need to be non-ionized or unionized across the membrane. However, they need to be ionized in order to function to block the influx of sodium. I'll explain that better in the next slide, but essentially they're weak bases. And who can think, what is a consequence of having anesthetic as a weak base? What problems can you have? That's hard, so I'll give you a clue. Think of the environment you usually administer anesthetics in. Any ideas? It's okay, it's hard. Usually you're going to give it, oh, inflamed, so acidic, they'll be beautiful. That's crazy. You got that. So usually they're administered in inflamed tissue when there's disease, and the pH is acidic, so the anesthetic is further ionized and less effective as a result. Where did my image go? Here is the image. You have the unionized form of the local anesthetic diffusing across. Then in the tissue, it becomes ionized and it blocks the sodium influx over here. Important to remember. Fibers targeted, usually small fibers are more susceptible than larger ones, and they're blocked first. So the order of blocking is pain, cold, warmth, touch, deep pressure, motor, and the order of recovery is the reverse of this. This is highly examinable. So when you recover, your motor is going to recover, then your pressure, then your touch, then your warmth. But when you block, because the small fibers are more susceptible, they're going to block first. This is just showing you the fiber size. You can see these fibers are really, really, really small. So these pain fibers are blocking first, whereas the heavy alpha chain, alpha fibers are going to be blocked last because they're quite large. Another important thing to remember is these are use dependent. So the areas in which nerves are firing the most frequently are the areas most targeted by anesthetics. So anesthetics target drugs in an open state or in an activated state, which means they have to have been depolarized, because to be inactivated, it has to have followed an open-end depolarization. And so it can better block polarizing in or to left. Yeah, that's a really good question. And someone asked that to Richard, shoot group last year. Someone said, why aren't the autonomics blocked if they are smaller? Then which one are they smaller than? I remember Jan asked that question. 8 delta. So this says autonomics are less than 2. Delta is 2 to 5. So why aren't autonomics blocked first? It's a good question, and I don't remember the answer to that question. Let me think if I can think of why autonomics would be different. The only thing, no, because they both release acetylcholine. Acetylcholine binds on nicotinic receptors in muscular things. In pain, it's autonomics are all efferent fibers, whereas these are all afferent fibers. I imagine that could make a difference. I don't know how that could make a difference, but it could be due to the release of the neurotransmitters. The answer is I don't know, and I remember Richard didn't know, so it's not that examined. Good question though, you're asking all the right questions. Yep, so these are better able to block nerves that are firing quickly. And in summary, almost done. Potency is determined by lipid solubility. And remember that the fibers that it targets depends on the fiber size, type, and myelination. The more myelinated it is, you can see these aren't very myelinated. They're going to be blocked quite quickly. These heavily myelinated are harder to block. Myelination affects it. Ionization status affects it. Remember, these are weak base. They work better in weak basic environments. In an acidic environment, it will antagonize the block. But remember, once it gets to the intracellular sodium channel component, it blocks it from the intracellular place. So it has to diffuse across and then block it from the inside. Inflammation reduces blockade. It's use dependent and depends on the frequency of nerve stimulation. Absorption depends on dosage, site of injection. Because that depends on the vasculature going to that area very well. Vasculature area will act differently to a low perfused area. That connects to blood flow as well. Drug, tissue binding, and vasoconstrictor factors. The reason why vasoconstrictor factors are often administered with adrenaline is they prolong the effect of the anesthetic. So it's going to reduce systemic kind of dissemination. And as a result, it's also going to reduce systemic adverse effects, which are quite serious. And you can see like they're from as low as drowsiness to as significant as cardiac arrest and respiratory arrest, which lead to death. They have effects in the CNS and cardiovascular system. They lead to depression. I wouldn't say you need to know much more than that. I don't know if Peter or Katja disagree with that. No, all good. And that is my slides. So what time is it currently? It's currently 12:43. I had a look at the lower limb. It's heavy text, and it's like describing bones. We went through lower limb last week as well. So I don't know. It's also going to take like an hour and a half. So what we might do is we might save that for next time. What are our thoughts of that? Sound good? Peter, Katja, any thoughts of that? IDK, if this is a weird question, but if you need to operate around the heart, wouldn't your anesthetic then affect? We don't have lower limb. Yep. So awesome. Good to wait. The question is, it's not a weird question. I don't know if this is a weird question, but if you need to operate around the heart, will your anesthetic then affect the heart too? It's a good question. I don't imagine you put the anesthetic in the heart because these are all local anesthetics. I feel like that would be like a general anesthetic that puts you to sleep if you're having full heart surgery. That's going to have a little bit different action. Could you upload the limb notes? Yeah, are they not uploaded? I thought they were. Okay, I'll upload them. That's a good question. Firstly, these adverse events are very rare, but the main complication with surgeries are the anesthetic. It's a good question. It does affect the prolongation, but I also imagine you're hooked up to a lot of devices that could supplement that. So like you could be mechanically ventilated and etc. I don't know the answer to that question, why, if you give an anesthetic to I imagine you wouldn't give an anesthetic directly to the heart. That would probably be very bad. But systemically how that works and whether it's the same action as a local anesthetic or putting people fully to sleep, or if because a general anesthetic has different mechanisms of action, which I don't understand how general anesthetics work at all, but you wouldn't put a local anesthetic by the heart. Yeah, because general puts people to sleep, local, they're still awake. So when you go to the dentist, they give you local anesthetics. Hopefully that makes sense. Yeah, thanks everyone for coming this week. We'll put up all these slides and yeah, have a good one. Good job on